This is a continuation of the previous patient. The inner knee has been suctioned, and now from a mid-thigh incision, the upper inner thigh is being suctioned. Again, the tunnels are made in the long axis of the body as much as possible so that we don't damage lymphatics and blood vessels unnecessarily. You can see the hands being used to stabilize the skin, as in all of these cases.
Here at the proximal part of the inner thigh, we have one of our 5 deep fat pockets, what is responsible for the contour of our thigh, how it ends up into the trunk, the stem part of our body. And so the cannula is directed downwards, and the movement of the cannula is not too superficial. You see sometimes the cannula rather superficial, but that's only accidentally. Most of the time the cannula is now here, more directed to the deeper parts of the fat pocket, and you will see that once you do a case like this, that there will be you will be receiving pure yellow soft fat.
And this is a good general rule for everywhere on the body except the neck. The neck, you can suction the fat very superficially without any problem, but in nearly everywhere else you want to leave a considerable amount of fat on the dermis. And Dr. Sattler is pointing out that we want to suction fairly deeply here so that we don't have postoperative skin irregularities.
Now we see here the blending of the whole area, and we how do you say
connecting.
We're connecting the areas, and especially the areas around the introduction holes of the cannula need to be treated separately.
And this is really a key sequence right here, because an incision has been made on the posterior part of the thigh just below the infragluteal crease, and from this incision you can crisscross the upper inner thigh with another incision which is made in the groin on the front, and we'll come to that. So there's some crisscrossing that gets done on the upper inner thigh in order to get a good result. So these are vertical tunnels in the long axis of the body, but also with some crisscrossing.
This is another view doing the same thing. Here we are working partly vertically, partly horizontally. One of the parts where it is allowed and sometimes even needed to be working horizontally.
And this is an area where you need to be careful. The fat on the upper inner thigh comes out very rapidly, and there needs to be a plan here and a method. And I think some liposuction surgeons will actually count strokes and ask that there to be quiet in the room during these critical areas so that they can really concentrate and not over resect any area.
Yeah. So also the visual control plays a very important role. You touch and make the pinch test over and over again till you have the final result. And you approach the final result very carefully and slowly.
And this is the incision that we talked about just below the groin, which allows us to crisscross the upper inner thigh area with that incision point that we used on the back of the thigh a moment ago. And this gives a very even result to the inner thigh. The inner thigh, I think, and I think Gerhard agrees, is one of the most difficult areas to do, and a lot of it has to do with the positioning of the patient and knowing exactly where to make these incisions.
Yeah. And as you see, in former times we started with that incision point and this suction point. Now we're ending the surgery with this point. So that's the reason for that is because we have so much respect for that.
And remember, we had that incision point in the mid-inner thigh, which will work as a drain hole for the tumescent fluid postoperatively. And the fluid will drain in most patients for 18 hours, and then it stops. If it drains for longer than that, then probably what's draining out is lymph fluid, and you've made too many tunnels perpendicular to the long axis of the body.